All right, hello, welcome to chapter 25. Today we're going to jump into neuromuscular conditions, and this is a section that we will stay in for at least through next week when we talk about conditions like Parkinson's and MS. So today we're going to talk about three things that are different inherently, but have pretty similar outcomes in terms of the scope of this class, and that will be stroke, brain trauma, and spinal cord injuries. So let's begin with the pathophysiology of stroke. So this is when there's injury to the brain from a critical reduction in blood flow. So 80% of strokes are due to a thrombotic occlusion or embolism, which is called an ischemic stroke. And then the other 20% are due to intracranial bleed, which we call hemorrhagic stroke. Um, Two-thirds of stroke survivors are left with chronic neurological deficits that persistently impair their function. Also, survivors have a very high rate of cardiovascular comorbidities. About 50% of them have coronary artery disease, and then about 3 to 5% of them unfortunately die due to cardiac reasons. So an interesting thing about strokes, which, we've all heard of them, maybe we all know people who've gone through it, but surprisingly, only 1 out of 10 produce overt clinical symptoms. The rest are called silent strokes. So these are usually undetected. However, they do take their toll. They add up cumulatively and produce cognitive impairment. And there seems to be quite a tie between the silent strokes and dementia rates. So there's a tenfold increase in dementia rates due to all of these silent strokes occurring. Also, when we talk about this population, recurrence is a very big thing that we also have to talk about. So, about 10% of survivors will have a stroke recurrence within their first year, and most commonly within just a few months after their first one. And then after that, it's about 3 to 5% recurrence rate annually. So, you can maybe tell where our management perspective is going to go into for this population. Now let's talk about brain trauma. So the specific one we'll talk about for this section is a TBI or a traumatic brain injury. So the way, you could call this a concussion, I suppose, but TBI is the encompassing term. So this is defined when the head is hit by an object moving with high kinetic energy or momentum, or when the head is moving with high momentum and it strikes a mass, whether it's stationary or moving. Now, why this occurs is, as we know, the brain is covered with the skull. It's encased in bone, and unfortunately, it doesn't have a good mechanism to absorb shock. So when anything happens, like either the head getting hit with something or the head hitting something, then unfortunately the brain tissue takes the damage and not something else. Now, it can be associated with intracranial bleeding, but it doesn't necessarily involve vascular injury. So, about 50% of all TBI cases are from motor vehicle accidents, and it's actually bimodal, who's at the highest risk. So, it's either people who are younger than 25 or older than 65. So, younger than 25 is, typically because of the motor vehicle accidents, and 65 and up is actually due to falls and things like that. Anyone who's had a TBI is typically at a higher rate, they have higher rates of headaches, chronic pain, peripheral vestibular deficits, difficulty initiating and maintaining sleep, depression, and deficits in cognitive functioning. So these are just some of the different cases you may work with. Additionally, there are persistent clinical issues regardless of the severity of TBI, which makes it really difficult to make a management plan for people who suffer through this. And there's actually research, interestingly, that the time being unconscious isn't actually directly related to how severe the TBI was. Um, so that's interesting. That's definitely something you hear when you watch sports, like, oh, they've been out for a long time, or oh, they didn't lose consciousness. It could have still, led to the same severity, regardless of loss of consciousness. So, some more research is being put into that, and we'll talk about that more a little bit later when it comes to exercise. But another thing to really keep in mind with TBI is that the main cause of seizure disorders among adults is from TBI, one of those persistent problems that they deal with. And there are two thoughts to why this may occur. The first one is the axonal injury within the brain, like perhaps that is causing some weird neural wiring problems or just messing up the way it's supposed to be working. And then another one is ongoing inflammatory pathways in the brain. So this is more like right after the TBI, but maybe these pathways continue and that's why these seizures may happen. So that's another thing to keep in mind with this population. And now let's talk about the pathophysiology of SCI or spinal cord injuries. So these affect about 250,000 to 500,000 people per year worldwide. Just like TBI, about half of them are due to motor vehicle accidents. Another 20% are due to falls or violence, and it's mainly gunshot wounds for this category. And then about 15% from sport injuries. And interestingly, in 80% of cases, males are the victim. So there was that joke a long time ago, and it's probably still true that women will live longer because men do crazy things. That's a joke, but in the case of SCI, perhaps it's true. Now, what characterizes SCI? So, they have variable sensory motor loss, but it really does depend on where the lesion occurred and completeness. So, completeness means, what was it completely, um, I guess, I guess, like, was the lesion complete, or is there still some partial innervation? So that all depends, which you can imagine leads to a lot of different combinations. So, some of the basic ways to talk about it. The first one is quadriplegia, and this is when the le lesion is above the first thoracic vertebra, and that means that all four limbs are affected. So either, again, depends on completeness, but either they don't have sensation at all, or it's altered. Paraplegia is when it's below the first thoracic vertebra. So this means that the upper extremities are not affected. Now, the most common that we see is incomplete tetraplegia, which is about 30% of cases, complete paraplegia, which is about 25% of cases, and then complete tetraplegia and incomplete paraplegia. And both of them are individually at about 20%. So those are the most common combinations that you will run into. So what are the outcomes? Now, these are quite a bit of, conditions that we've kind of put together in one chapter, and that's because their outcomes are pretty similar. So the way we deal with it in exercise is going to be relatively similar. So, some of the common issues that we see in these three populations are chronic gait and balance deficits beyond 6 months, increased fall risk, hyperreflexia, spasticity, and clonus, core body and leg problems, and pathological reflexes that change the base of support at the ankle. Now, in general, these three conditions might contribute to gross muscular atrophy, increased intramuscular fat, the shift from oxidative to non-oxidative muscle fibers that are insulin resistant, which we will touch on more in just a little bit, and metabolic syndrome. So, what are some of the systemic effects that we see from a central nervous system injury, which is essentially what all of these are? So that impaired glucose tolerance is an interesting one, right? Because we've talked about it in the past with diabetes. Um, and they also develop type 2 diabetes for over 75% of people who have a stroke and survive. For the spinal cord population, a lot of them develop metabolic syndrome. And then for TBI, again, increased insulin resistance for their muscles, and for everyone, they all experience reduced bone density, and that leads to pathologic fractures. And this is more concerning for the spinal cord injury population because perhaps those fractures occur in places where they don't have innervation, so they actually can't tell that they have a fracture, which might sound like, oh, that's good, they don't feel it, but no, it's bad. You'd want to address it, right? So it's particularly concerning for that population. Now, to continue, they also have some autonomic abnormalities. So these are different types of dysfunction of sympathetic control of circulation and chronic pain. Now, mainly for the spinal cord population, they have autonomic dysreflexia, And this can dangerously raise their blood pressure, and it's usually triggered by pain or bowel bladder dysfunction. Um, Mainly for the TBI population, they have an exaggerated startle and pressor chronotropic responses. And then lastly, for all of them, chronic regional pain syndrome with a limb pain syndrome sensitive to touch with swelling and bone resorption. So as you could see, a lot of different effects happen because of CNS injury and all things that you have to keep in mind when you're going to work with them. So, how do we manage these conditions? What are some medications people may take? Well, this is a wide range of conditions, and the focus is slightly different for each group depending on what the condition is. And that's mainly because it's focused on secondary prevention of their recurrent vascular events and then management of the post-event sequelae. So, some common medication that you may see are antiplatelet medications. Now, this is mainly for the stroke population, and it's been seen to reduce the relative risk of it by about 20 to 32%. The statin therapy for lipids and vascular function is also really helpful. Even if their lipid profile isn't elevated for these populations, it has been prescribed for them to take anyway. Antihypertensive medications, and that's just for the cardiovascular concerns that we've talked about with some of these groups. Anticonvulsant medications, that's for the people with TBI who have seizures, and then stopping tobacco smoking if they are smokers. To continue, here are some of the different management techniques. So, comprehensive stroke care is a big one. So, they go to physical therapy, occupational therapy, speech and language, swallowing, all of the above, right? So that's one form, and that is where you might meet one of these patients, right? Surveillance and treatment for depression and depressive symptoms. Ankle foot orthoses or functional electrical stimulation for foot drop and alignment. Now, if you don't know foot drop, it occurs in a couple different populations, not just here, like Parkinson's also deals with it, but um, it essentially makes their foot like slam into the ground when they're walking instead of having, slower control over it. So we'll talk about that more for Parkinson's, but this may be like stroke care or TBI care. And then, of course, walkers, canes, wheelchairs, any type of mobility help that they may need. All right, let's talk about exercise. So, what are some of the effects that we see of these conditions on the exercise response? So, after someone has a stroke or an SCI, peak aerobic performance is about 50% below that of matched sedentary controls. So, it really does take quite a toll on them. And we see this for a very obvious reason where the energy cost is just a lot higher for this group. Um, so for walking, and this is for stroke, energy costs may be about 1.5 to 2 times higher, and that's mainly due to abnormal gait biomechanics. So if you're not walking with a more efficient way, then it's going to cost you more. And this unfortunately means that most stroke survivors are unable to independently perform their ADLs. And now stack that with maybe a recurring stroke, and you can see how this really spirals for them, right? And for a spinal cord injury group, it's actually 5 to 10 times higher the energy cost of locomotion. So that's why we see a lot of these decreases in their performance when matching to other sedentary groups that don't have these conditions. So that's definitely something to keep in mind and try to address with exercise. Now, for stroke specifically, interestingly, they can achieve about 85% or greater of their age predicted maximal heart rate. And that indicates to us that the cardiovascular side of things isn't exactly the rate limiting factor for, how well they can do or how they can, get back to the norm before the stroke. For TBIs, this is contingent on their severity. So if most TBIs are considered mild, um, however, it depends. Everyone's response is a little different. And I'll have a special section at the very end of this where we'll address some of that. But just note that it really does depend on how bad the TBI was. And then for the spinal cord injury group, now the American Spinal Injury Association has an impairment scale, and we call this AIS, and this helps to categorize them into some level. And that can actually really inform what type of exercise they can do. Now, what we do see is that they can have markedly reduced muscle activation, and this leads to profound muscular atrophy, which is why that electrical stimulation and all that management is even more important for them. Also, if they have a lesion that's at or above the thoracic vertebra 4, that can lead to a blunted chronotropic response to below 130 BPM, even in young adults. So, yeah, the heart rate response may be very different than what you would expect. All right, what are some effects of exercise training? Now, surprisingly, I don't know if this would surprise you. It surprised me just a little bit. The way to focus on exercise for these groups is actually not all that different from any of the other chronic conditions that we've talked about. The only main difference is that you have to give an increased attention to neuromotor function and balance to safely adapt exercises to the person's neurological deficit. So that's the main thing. You don't have to reinvent the wheel. You just have to have some increased attention on these specific things. And like many other conditions we've talked about, here are some of the improvements that you can see for this group right here. So, aerobic capacity and cardiovascular disease risk, glucose tolerance, brain blood flow and brain function, muscle function, mobility, and bone health. Now, the glucose tolerance one, um, this is, I think, a good time to talk about that. So, we did talk about how some of the muscles go from the more oxidative to non-oxidative switch, and that's not that's not great because when they're doing low intensity exercise, which is typical ADLs in a regular day, then they will get more tired if there's that shift to non-oxidative. And so they won't be able to perform their ADLs and they'll get more fatigued doing very light to moderate exercise. So as you keep, going through their exercise training program, this glucose tolerance will improve and that muscular capacity will also improve. Now, specifically for exercise programming, what's recommended is follow the CDD4 guidelines. If the people are, very high functioning and, maybe they had a history of, exercise and regular strength training, aerobic training, then you can actually use the ACSM guidelines. But here are some specific things that you may want to consider. So number one, it has to be safety first. So regarding equipment use, whatever equipment it may be, you have to try and minimize fall risk as much as possible and make sure that clearance and mobility from these equipment is not going to be a problem for them. So that's the first thing that you have to really watch out for. Using therapist input, so initial and follow-up assessments, and this is just to see how they're progressing and what route to go for the neuromuscular adaptations or, whatever the focus has to be for that individual. Adaptive equipment is also, it would be very ideal. I know not every clinic will have stuff like this, but if you do, then that'll be great. Like, for example, a treadmill with a harness over it, that would be amazing for a group that, isn't exactly walking the way they used to before this event, right? And then for mode, it's up to the individual, their choice and their compliance. We want them to comply and to stick with the exercise program. So if they like the reclined bike, then why not, right? So just look at that for what you should choose for them and help them to use. And then in general, for the warm-ups, make them slow. Intensity use perceived exertion because of those heart rate response abnormalities that we talked about. For pressor response, so observe for signs of low blood pressure as well as very high blood pressure, which is common to occur in the first 6 months after the event. And then just watch out for body temperature as well. So SCI can produce abnormalities of body temperature regulation. Um, So these are just, again, some factors that you'll have to keep an eye on, but otherwise, going through exercise with this group is not all that different than the other chronic conditions we've talked about. Just have to shift your focus to the specific neurological deficits that the person you're working with may have. And now this is the end of my slides. However, I'm also going to add some special recommendations for TBI specifically. So because it really depends on the severity. And as we talked about, some common thoughts are not what we think they are. Like, oh, they were knocked out for a long time. That means it was a really bad case of TBI. Not necessarily. So because of that, it's actually recommended that there's a period of time right after the TBI that you don't get back to exercise. You need to take a break. They call this cognitive rest, and it helps to facilitate recovery. And in general, pretty good rule of thumb to use is when they do get back to exercising, whether it's with you or you're the therapist or whoever you may be, if they experience any type of discomfort with the activity, that's a pretty good sign that they're not ready yet. So you can use that as a rule of thumb, but really take it individually and see how they're progressing. Now, in contrast, for the SCI population, you actually want to get started as soon as possible. Early mobilization and exercise training is really important because atrophy occurs so quickly. Also, remember to use that AIS scale to select the exercises for that group. But even within the same classification, you may see a very wide range of symptoms and, recurring problems. So just note that every individual is going to be very different, even if they are at the same classification. And yeah, so hopefully you guys found this interesting. We will continue with this next week. Um, and yeah, we just have a couple more chapters to go and we're actually done with the semester. So yeah, have a good weekend and yeah, I'll see you for the next set of videos.